Lower gastrointestinal bleeding. What is lower gastrointestinal bleeding? Lower gastrointestinal tract bleeding is defined by any bleeding in the GI tract, distal to ligament of Treitz. Majority of the lower GI bleeding is self-limiting. Only 10 to 20% patients present with massive lower GI bleeding in 90% of the cases. Colon is the source of bleeding. Incidence increases with age, as the causes are age-related. Most common cause of significant lower GI bleeding is diverticular disease. Differential diagnosis of lower GI bleed. It involves one of following three causes: structural, vascular, inflammatory. We will discuss them one by one. Number 1. Structural causes: diverticulosis, post-polypectomy bleeding, hemorrhoids, polyps, malignancy, anal fissure, aortoenteric fistula, colonic and rectal ulcers, Meckel's diverticulum. Number 2. Vascular causes: acquired, sporadic angiodysplasia, colonic or rectal versus vascular anomalies related to congenital, systemic disease, HHT, crest tumors, hemangiomas, Kaposi sarcoma. Number 3. Inflammatory causes: ischemic colitis, IBD, infectious colitis, radiation colitis or proctitis. Important note for GI bleed in OLD patients: massive bleeding usually occurs in patients older than 65 years with multiple medical problems, and this bleeding presents as hematochezia or bright red blood per rectum. The patient is usually hemodynamically unstable with a systolic blood pressure, SBP, equal to or less than 90 mm of mercury, heart rate, HR, less than or equal 100 per minute, and low urine output. Lab work reveals a hemoglobin equal to or less than 6 grams/dl. Massive lower GI bleeds are mostly due to diverticulosis and angiodysplasias. The mortality rate may be as high as 21%. In case of moderate bleeding can occur at any age and presents as hematochezia or melena. The patient is usually hemodynamically stable. Many disease processes should be considered on the differential list, including neoplastic disease, inflammatory, infectious, benign and rectal, and congenital. Finally, for invisible bleeding. Occult lower GI bleeds can present in patients at any age. Lab work reveals patients with microcytic hypochromic anemia due to chronic blood loss. The differential diagnosis of these patients should include inflammatory, neoplastic and congenital. The patient typically appears well, hemodynamically stable. Important points while taking history of patient: onset, acute, ischemia, Meckel's diverticulum, angiodysplasia, chronic, piles, IBD, Ka, polyps, age, less than 50 octoseconds, infection, anorectal disease, IBD, greater than 50 octoseconds, malignancy, diverticulosis, any age, piles, pain, painful, anorectal lesions, anal canal, piles, painless, polyps, Meckel's diverticulum, pain in relation to defecation. On defecation, piles, anal canal. After defecation, solitary rectal ulcer. 5. Tenesmus, rectal Ka, ulcerative proctitis, irradiation proctitis. 6. Abdominal pain and bloody diarrhea, IBD, infectious diarrhea, Ka colon. 7. Nature of blood in stools, anorectal bleeding, straining and passing of hard stools, with dripping of blood, piles. Blood may splash or drip after defecation, anal canal and rectum, streaking of blood on stools. 8. Color of stools: brown stools streaked with blood, rectosigmoid or anal cause, large volume of bright red blood, colonic source. Black stools, upper GI bleed, maroon stools, small intestine or right colon, bright red blood, anal canal. 9. Past history: radiation, heart disease, mesenteric embolism, drugs, warfarin, heparin, NSAIDs, liver disease, variceal bleeding, chronic renal failure. Management of lower GI bleed: establish 4 access, large bore, and start 4. restore volume and replete red blood cell deficiencies, lab CBC, electrolytes, coagulation profile, blood type and cross-match. All coagulopathies require reversal. Esophagogastroduodenoscopy inspects the esophagus, stomach and duodenum. Colonoscopy studies shows that colonoscopy can identify definitive bleeding sites in more than 70% patients with lower GI bleed. Capsule endoscopy, a small pill containing video camera transmit images of small intestine. Balloon-assisted enteroscopy, a wireless scope inspects part of small of intestine that EGD and colonoscopy cannot reach. Endoscopic ultrasound, an ultrasound probe attached to an endoscope shows all the layers of tissue of digestive tract. Cord enterography involves ingestion of a neutral contrast agent to distend the small bowel followed by cord imaging of abdomen. MR enterography, an alternative to cord enterography. It has advantage of not using ionizing radiation which allows for sequential images of small bowel. Nuclear GI bleed scan, identify active hemorrhage. Angiography, following is a flowchart showing how to manage a patient with lower GI bleed. First, check whether he is hemodynamically stable. If he is stable, then we will do colonoscopy to identify the source and treat the source of bleeding. If colonoscopy didn't identify the source, then next we do EGD as second line for identification of source of bleeding. Important note: if patient is hemodynamically stable and gives history of single episode of self-limited hematochezia and negative initial colonoscopy, can be observed closely without further testing. If patient is not stable, first resuscitate the patient and then do emergent EGD to identify the source and treat the source. If source is not identified by EGD, then we will do colonoscopy to identify the source and treat the source. In cases when both EGD and colonoscopy proved futile, then this case will be classified as obscure GI bleeding. Now we will decide whether to repeat EGD and colonoscopy, or keep patient under close observation, or do CT angiogram of abdomen or pelvis, or do push enteroscopy, or do tagged RBC scan, or do capsule endoscopy.